you know, what's interesting to me in all this session, we spoke about different approaches countries took and different methodologies. But I think one element that play a central role in all countries and how they utilize data. You know a little bit about it. All the work you've done with data and data-related innovation in Israel. How do we use data in this pandemic, and how at your organization, Clalit, who's doing a lot of work around prediction and proactive approach, where you're taking data in trying to form a policy?
So, you know, we were very fortunate to be that in this country, we had a great infrastructure to work with when trying to use data for practice in healthcare. This has not started in this pandemic. This is something that has been ongoing for at least 20 years. Back in the 90s, then the decision to make all of the digital records available and having 100% of the electronic medical record fully digital, and at Clalit, responsible for 4.5 million members, we have millions of records to look into and to use in order to improve the practice.
So how do we take, assuming that you have millions of records which are accurate and long time and tagged records, how do you take these records in order to have a better prediction in a time of an epidemic?
So you need to have some kind of a backbone. So the approach that we've been taking before the pandemic was one of what we call predictive proactive care. That means that when we look both at infectious diseases, complications, and especially on chronic diseases, non-communicable diseases, we also use the same approach. And it goes like this. When a person comes in with the signs and symptoms of an overt disease, usually it is fairly late in the pathological process. And at that point, it is quite difficult to have a strong impact on their outcomes. And it is so much more effective to make an impact when you come early on, when the patient is still what we call pre-symptomatic, when his symptoms and signs only begin, or when there's small changes in his lab tests and in various other information sources that tell us that he's about to have a disease. And so one of the things we tried to do over the last decade and a half is to have predictive, proactive care in practice. Let me give you one practical example. So we all know chronic kidney disease, and we know that when you have the signs and symptoms of chronic kidney disease, it is fairly late and there's very little that you can do in order to avert the consequences, maybe just delay them a little bit. So what we did is we took the data of the patients that have become patients with end-stage renal disease. And we've been able to look back 5 years and identify which characteristics are most classic for these patients that will be deteriorating. And then we have approached our patients 5 years before they were deteriorating, when they were feeling good and they were looking good. And we proactively approached them. And we said, you need to come to the clinic, not because you feel bad, but because we have an indication that in the future you will have a disease, and right now we can do something about it. So we did this for chronic renal disease, we did this for diabetes, we did this for cancer, we did this for heart disease, we did this to prevent stroke, we did this to prevent osteoporotic fractures. So there's been a backbone of many years of doing predictive, proactive care on the massive scale, both in primary care, but also in specialty care and in the hospitals.
But you know, you've done marvelous job at normal times with prediction and predicting actually disease before they happen. But now I take you to February. We understand that there is a pandemic, and now you need to do it at a scale, and not on the individual level, but on a country level. How do you take tools that were utilized on an individual level and take them into a policy making or prediction at a country level?
So I think that's a classical dilemma. And let's take the example of February. At that point in time, there were very few patients in Israel that we could work with. But we did get some data coming in at that time, at the beginning from China, and then information coming in from Italy. And we had in our backbone a predictive model for influenza complications. And every winter, we identify the patients that are the highest risk of influenza complications, and we come early to them, and we try to advocate vaccines to them in a very intensive way. We took that predictive model, and we, within our team at the Clalit Research Institute, we have adapted that tool to actually fit the characteristics of those patients having complications of COVID-19 very early on, even in February. And at that point in time, when disease only started disseminating in Israel, we already had in place a predictive model for the entire population. And we identified 200,000 people that we thought that would have the highest risk of having a complication, of having some of the severe complications of COVID-19. We approached them, we contacted them, and we told them, stay home. Don't come to the clinic. Try to not to leave home as much as you can, because the disease is now really disseminating. And with SMS messages and with phone calls from their physicians, we managed to keep them at home and to tell them, use our telecare services instead of our normal care. Don't come to the clinic right now.
Could you, so you called 200,000 people, which is a large volume of people, and tell them, stay home, you're at risk. But you still need to do caregiving to them. I understand that you also took some dramatic steps at care providing at home for these individuals. How do you use technology and data for providing services to individuals at home?
So one of the things that we've done, and we will talk about today in one of the sessions that we will have later, is the issue of home monitoring and hospitalization at home. And we know that pandemic is usually thought about as a disease of the hospital setting, but actually pandemic is a disease of the community setting. The vast majority of patients do not require admission, but if you do not give them proper care at the community setting, they will come in and they will flood your hospitals, and they will not allow you to have the right sufficiency and to deal with those patients. And so we created, with the help of local startups, various mechanisms for home admission and home hospitalizations and home monitoring of these patients. We have given them, and they are getting until this day, when a patient is diagnosed and he's in the risk groups, he gets a package to his doorstep with a pulse oximeter that can contact directly to one of the apps that we have, so we can follow up. And with specific directives, we also work with a local startup called Taito, with a actually handheld device that allow you to do a full physical checkup from afar. And we use this both in the home setting and in the hotels that we've used in order to keep the patients quarantined. So I think this is an interesting combination. And what we were really interested to find out is that some of this had a real significant impact. You see, at the early stages of this pandemic, we were really worried about the mortality rates. But what we saw that Israel had one of the lowest mortality rates globally, even in the first wave, but also in the current wave that we are experiencing right now. And one of the reasons, now we have the actual scientific proof to that, is that a lower proportion of the elderly and at vulnerable subpopulations were inflicted and were infected as compared to the rest of the segments of society. And that actual percentage continuously decreased through the event, probably due to this predictive, proactive approaches that we've been taking.
But what can you say? You know, I try to imagine an 80-year-old person that you identify them at risk, and now they are told, stay at home. They get this package of some digital gadgets they never played with before, and now they are being monitored by technology. Share with me a little bit about how they adapt to technology, what the experience you had with them.
So, you know, we had our doubts at the beginning, but apparently any age group can adapt to technology as long as you do the implementation correctly and you do the proper explanation and make it be as easily understandable to the average person. And you need to have this culturally adapted, and you need to have it adapted to different languages. And of course, in terms of anything, even the size of the fonts that you have are important if you want to reach some segments of society. I think that the most interesting latest point that we've been able to put in AI-driven care, and this is something that is presented for the first time here today, is something that we're putting in practice right now. And that is, we've created a predictive model for who is going to be infected by coronavirus on a personal level. We now digest data from our entire systems, data on the family members that have been afflicted by the disease and people in the vicinity that have been inflicted by the disease, and the personal characteristics of the person and the risk that they have, a priori risk. And we combine all of this together, and every person, every day, every member of Clalit gets a score of how likely he is to be positive to COVID-19 should he be tested. And when such a person now walks into a Clalit clinic, the physician in front of him can actually see. This is something that is coming in the latest version of the electronic medical record now being introduced. The physician can see their risk. He can see that this person in front of him that comes in for a back pain is at high risk for COVID-19 because of all of these different components together. And he asked them, by any chance, have you had any respiratory symptoms in the last few days? Maybe you lost the sense of smell or taste. And so in a proactive manner, we're trying to find those patients based on a predictive model of their chances of having COVID-19.
So basically, you managed to do a personalized caregiving experience, just as we had it in the digital space, but now in the physical space, based on individual risk scoring and individual data classification.
Yes, and what we're going to do next is to find out those patients who are both at high risk of COVID-19 and high risk of COVID-19 complications, and we're going to proactively send them our symptom surveys. And if they are, if they have any signs and symptoms, then we do the PCR testing to them. So then we close the full circle of proactive care on COVID-19. So I think these are some points to think about on how you can actually adapt AI and data into decision-making at scale. And what I'm talking about here is not something that we do for a clinic or a hospital. This is done countrywide to over half of the Israeli population. And from the minute you do the go, then it is in practice all around the country.
Wow.